So again, welcome, and I am going to hand this over to Anne to get started. Thanks, Anne.
Hi and welcome. Thank you so much for volunteering this year. And welcome to our crash course in how to talk about healthcare payment reform. Thank you for making our presence at the Minnesota State Fair the success that we know it will be. We have a serious purpose for being there, but I also want to encourage you to enjoy the event, maybe come a little early or stay late and visit some of the other vendors. Um, Probably most of our conversations will be brief, but some will require you to have enough background to answer some questions and maybe get some of our contacts to take next steps in supporting this issue. So this training is meant to give you the information you need both to participate in this event and also to give good information out to those who take time to talk to us. This is our opportunity kind of to interact with the general public, everybody who comes to the Great Minnesota Get Together. So the State Fair this year is Thursday, August 24th through Labor Day. I'll just give you a couple of some volunteer basics. We're in a post-COVID-19 era, but it still kind of hangs over us or hangs in the background. Current guidance from the Minnesota Department of Health regarding COVID-19 is that there are no special precautions in place at this time. Community spread is relatively low, especially in the counties of Hennepin and Ramsey County. Any precautions are an individual responsibility and based on your own health status and your own assessment of your risk. We will have some hand sanitizer available just because it's kind of a good basic practice. If you feel you need to wear a mask, bring one. I obviously, as a healthcare professional, I'm a strong believer in vaccination. So hopefully we're all vaccinated for COVID-19. We will have a small supply of masks available, not fancy, but maybe just the surgical type. And then be sure you are well with no symptoms of COVID-19 or other respiratory or other communicable diseases. Of course, parking is always an issue at the fairgrounds with the state fair. I would be remiss if I didn't suggest public transportation, but I've got a few other hints for transportation on another slide. Also, think comfortable shoes, water, rain gear for walking around the fairgrounds, layers for cooler or warmer weather. We will have t-shirts for the organization you are representing, whether it's Physicians for a National Health Program Minnesota or Healthcare for All Minnesota. And please come a little early for changes of shift, for setup and for closing, setup at the beginning of the day or closing at the end of the day. This is a map of the fairgrounds, just for you to take a look at the general layout of the fair. If you haven't been there, most of us have been there. We are right on Snelling Avenue, near the Snelling Avenue entrance to the fair. And this is what the education building looks at on the outside. I think of it as a 1960s cinder block building, but that's the exterior of the education building. And a close-up is we're to the right of the Snelling Avenue exit. The first building at the right of that big entrance is the creative activities building, and then next to that is the education building if you turn right. So parking is a challenge. The main gate is south of the parking lot at the Larpenteur Avenue exit. It opens at 7 a.m. You know what? I need to double check the cost. That might be from last year. And then you can see the map of the fairgrounds for lots. The Gortner Avenue ramp is via Larpenteur Avenue on the north end of the fairgrounds, and that's a University of Minnesota ramp. I believe that's still $15 a day. And then there are other St. Paul campus.
Last year when I parked there, it was $20 per day. So
oops. Okay. It's really convenient because it's usually parking is available. If you happen to be coming by motorcycle, that's an odd thing, but there's parking at the Como lot and bicycle parking. The Snelling Avenue entrance should be open for walking in. There are also buses going up and down Snelling and Como. And then discounted tickets price can be purchased online up through August 24th. I think I'm sorry, August 23rd this year.
And I
And
just,
then-
sorry to interrupt again, Anne. Also, tickets can be purchased early at a discounted price at some Cub Foods. So if you shop at Cub Foods.
Oh,
you get-
that's right. Mhm. And then there is a ticket counter right on Como Avenue. If you want to just drive up and purchase physical tickets at that Como Avenue ticket building. And then there's right down at the bottom is a website for the Park and Ride locations. Park and Ride actually works pretty well. There are a lot of businesses, churches, and public venues that offer a parking lot and a place to get on a bus. So we are in the education building on Cosgrove Street on the, if you look at the State Fair map, we're in booth 21. It's a corner booth toward the east side of the building. So think the building backs up to Snelling Avenue. It's on the far end of the building when you walk in that entrance that you saw in the picture. We will have written materials, buttons, business cards for both Healthcare for All Minnesota and Physicians for a National Health Program Minnesota. There's a banner up behind our booth, and we will have some activities. If you have an organizational t-shirt, please wear it, but we will have some at the booth also. Our goals for this event are to have some good conversations, build our base of support for reform, grow our social media following, perhaps support a petition to pass the Minnesota Health Plan, and then learn the concerns of people who stop by. You'll see when you get to the booth that we'll have clipboards, pens, QR codes for signing up for both social media and for our mailing list, electronic tablets if their phones aren't working, we can have people sign up electronically. Clipboards are available if people want to write their contact information down, but I can tell you from doing lots and lots of data entry that it's by far better to have people sign in electronically so that it's accurate. And it's also instant. They instantly get a response from us, a welcome letter. And then we will have some activities for conversation starters, along with the posters and banners. We've got a subcommittee working on at least one new activity for our booth this year, I guess, to be determined. You'll find out when you get there. And then, oh, interesting. A little general information. I'll have this information at our booth. There's a number for police and non-emergency for information on it, and then police, fire, and emergency, which is 911, and then contact information for Jen Crawford, Judy Barton, and Ann Jones are coordinating the event, and those are our phone numbers if you need to get a hold of any of us. Our booth needs to be staffed from 9 a.m. to 9 p.m., except we'll close at 8 p.m. on the last day on Labor Day. Our staffing plan is 2 6-hour shifts, 9 a.m. to 3 p.m. and 3 p.m. to 9 p.m. Many of you may have already signed up, but that's what our staffing plan is, plus 3 4-hour shifts during the day, 9 to 1, 1 to 5, and 5 to 9, so that we have some crossover and continuous coverage. We should have at least 2 people in the booth at all times, and likely there'll be at least 3. You'll also have a resource person either present or available by phone. And please don't think that you have to know everything as a volunteer. We have lots of handouts, a form to take down any questions you can't answer, and a resource person. You'll likely be with somebody who's pretty experienced at answering questions and fielding holding good conversations and fielding anything that might come up that's unusual or challenging. So this issue is serious and important. but it's the state fair. So we also want you to have fun being there. This is the form I talked about, that if you get a question that you can't answer and there isn't somebody there with you who can answer it, you can write it down along with contact information so that one of us can get back to that person if it seems necessary. We also will have a form available if you talk to somebody who has a really compelling story that they would like to tell, are willing to tell. Go ahead and let them write it down. Sometimes people do share a lot of information if this is an issue that they really care about, or especially if they've had bad experiences or are in the middle of a problem with our healthcare system. Go ahead and let them write it down. Make sure that they know that their story will be kept confidential, and we will only use it as an anecdote to illustrate the reason we're working on this issue. So, again, our goals are to have good conversations, listen, learn, maybe offer some information about what you know about this issue so far. We really, really, really want to build our mailing lists for both Healthcare for All Minnesota and Physicians for a National Health Program Minnesota. We want to educate the public about the possibilities and benefits of single payer financing for healthcare and a state-based versus a national health plan. We want to build support for the Minnesota Health Plan via our online petition. Sorry, I should have changed this one. This is not an election year, and we do have a legislature friendly to Health and Human Services. So we'll be looking forward to a session coming up where we may, we hope that we will be able to have hearings on the Minnesota Health Plan, which was reintroduced this last session, but no hearings were held. There was some other important healthcare related legislation that you may have learned about at our post-session quarterly meeting, and we will continue to inform people about. We want to build support for a public solution to the problems of cost, quality, and access to healthcare in Minnesota and the U.S., and enforce the fact that we are a community. And this is something that requires a solution that makes us and reinforces us as a community. So who are we, and why are we going to the Minnesota State Fair? Well, we are Healthcare for All Minnesota, Physicians for a National Health Program. We are nonprofit, nonpartisan issues organizations working to educate the public and fix how we pay for healthcare in Minnesota. As advocates, we educate, organize, and legislate, meaning we provide education on the problems with cost, quality, and access to healthcare. We organize the public and providers to build support for change, and we work with legislators and congresspersons to pass and implement reform. Healthcare is not, or should not be, inherently political, but unfortunately has become politicized, in large part because it threatens the business model of those who profit most from people who need healthcare in this country. We believe in putting patients ahead of profits, and that healthcare is a public good. So this means crafting a public solution for a public problem or a public need. And if it helps to illustrate this point, you could share with people the fact that we already do a lot of things together as a society. Healthcare is really no different. If we put people first. And this is my example of a list of things that we have already agreed, or basically agreed, that we do together, and people are all familiar with all of these services. And I think if you keep this in mind, it might help the conversation a little bit. Say, well, we do schools, we do libraries, we do parks, we do police and fire, we do snow removal, we do emergency assistance, we do a lot of things together. The military, the National Weather Service, this could be in the constellation of things we do as a society, as communities, including we already do Medicare, Medicaid, and Social Security together, and they work pretty well. So if people seem skeptical about a public solution to healthcare for everyone, perhaps, this is a good illustration of things that we do together, and let's just add healthcare as another one. So how do you start? I mean, you're going to have people coming up to you. We have a big banner behind our booth that says, "Help us fix Minnesota healthcare." I sometimes people will look at the banner and say, well, is there a fix, or what's the fix, or and that'll be an easy way to start. But if people stop and pause, I would suggest just an open-ended question like, is the cost of healthcare in Minnesota a concern for you? Or if they're already with us, would you like to help us fix how we pay for healthcare? Those are easy, conversation starters. Answer questions. You can offer initial, additional information, give next steps. I've found that simpler is better, and an open-ended question gives people a chance to ask or start a question. We have business cards available, a brochure. We have a trifold brochure that gives a pretty good explanation of the proposal for Minnesota. We have buttons. We have a lot of kids will stop by because we'll have a wheel to spin that says Wheel of Misfortune, and that's sort of eye-catching. And like I said, we might have a couple other activities at our booth that will give people a reason to stop and maybe have a conversation with us. So again, if you can, if the conversation seems to lend itself to this, ask for contact information. And then if they're interested, they can support our online petition. We do also have QR codes for our Facebook or our social media sites. I said the Wheel of Misfortune is a conversation starter, and then look for a couple of other activities at our booth so that you can be familiarized with when you get there. There are other handouts in a file box. We have a file box under behind the table cover that says Healthcare for All Minnesota with a lot of information, including a one-page summary of what Healthcare for All Minnesota is all about, frequently asked questions, information on legislation. Also, something we're really trying to help people understand is that our public programs like Medicare are under threat of being privatized and monetized. And if people come along that are like me with gray hair, you can maybe offer them a handout on threats to Medicare so that people can be informed about what's happening and what we're concerned about with Medicare. We are also working hard with legislators to deprivatize or get the insurance industry out of Minnesota Care and medical assistance, which is Medicaid in Minnesota. It's costing us millions of dollars to allow third-party payers in our public programs. So, what do I say when things come up like that? You might run across people who stop by and say, well, are you selling insurance, or what is this all about? Make sure people understand that we are not selling insurance. We are trying to fix how we pay for healthcare. If people need help immediately to get coverage right now, you could refer them to the MNsure exchange, and there I will have a phone number for the exchange at our booth if they need access to insurance right now in the ACA insurance exchange. And then just because Minnesota Care, a lot of these words sound a lot alike. Minnesota Care is one option via that exchange, just so people understand. For help right now, we have business cards with their phone number on. Open enrollment is coming up, I suppose, in October-ish. So just so be clear with people that we are advocating healthcare payment reform. We're not selling insurance. If they use terminology with you like government-run healthcare, government-financed healthcare. I would reframe that by saying that government, under the proposals that we favor, government is the payer, not the provider. If they use, throw socialism at you, one of my favorite responses is to say, socialism is when we prop up multi-billion-dollar commercial insurance companies with taxpayer subsidies for premiums and reinsurance. You might want to keep that in mind. That is corporate welfare, as Paul Wellstone used to say. We advocate freedom of choice, freedom up to choose your doctors, hospitals, drugstores, not choice of commercial insurance policies. And then competition should be about competing for your business based on quality of service. Under our market-based system, it's really about monetizing our system. And competition should be about you get to go where you want to go based on what works best for you. Free means prepaid. We're not talking about free stuff, which it gets thrown around a lot. Free in this sense means prepaid via tax revenue or premiums based on ability to pay, and free at the point of care to remove the barrier of cost to getting the care you need. We have also a handout on frequently asked questions about the Minnesota Health Plan, which is a good reference. You'll find that not a lot of people are familiar with the fact that we actually have a proposal for state-based insurance that would be funded and administered right here in Minnesota. As opposed to Medicare for All, which is a phrase a lot of people are familiar with, going all the way back to the 2016 election cycle with Senator Bernie Sanders' proposal for Medicare for All. That's a national health plan. The Minnesota Health Plan would be state-based. So what about those difficult situations that you might encounter? Do not feel that you have to convince everyone about our issue or our cause. If someone is extremely oppositional or negative, feel free either to pull them aside and suggest that we talk away from others, or just say that it doesn't look like this is for you at this time. Try not to let people waste your time arguing with things that are kind of tangential or anecdotal. Offer them information and just wish them a good time at the fair. Thank them for stopping, and then take down any questions and let them know that someone will get back to them with information and answers if people seem genuinely interested and it's not just a distraction. Okay, couple things. One kind of an organizer 101 is having not only getting contact information so that we can stay in touch with them, but also having next steps. If people say, I'm with you, I'm interested, what do I do? What do I do next? Obviously, let them know that giving us their contact information means they will get a newsletter from us. They'll get information about upcoming events, opportunities perhaps to volunteer themselves or donate to support this work, and opportunity, information that they can share with other people. So, and perhaps helping us amplify our efforts via our social media platforms. And then let them know that we have information and previous or lots of videos on our YouTube channel. Also, we have a calendar of events on our website. We're at the State Fair this year, and our next scheduled meeting or event will be our fall update, which is Thursday, September 14th at 6:30 p.m. via Zoom. All of our classes and meetings are via video conference. And then we will likely resume some monthly educational events in October. The other reason we ask for contact information is so that we can send calls to action. If we need people to act, as in contacting their legislators, contacting their members of Congress, or show up at a hearing, that's how we would communicate with them, was via email. So all good reasons for them to share contact information with us. And then basics about our current system. What I just covered is kind of what you need to know to be a volunteer at the state fair. The rest of this is kind of some basics about our current system, and you are welcome to stay on for as long as you have time for us this evening. This is just background so that you feel confident that you know what you're talking about when you're talking to the general public, who have a whole range of understandings about our current healthcare system. So this is kind of a crash course in our current healthcare financing system. Just basically, we vastly overpay for healthcare in this country, not because we're getting better care than everybody else in the developed world, but because of the waste, inefficiency, and complexity of our current system. We're not getting our money's worth, and we leave far too many people out. We don't have to come up with a lot of new money to finance, to fix this. In case people ask you, which many people do, is even if they're with you, they might say, well, okay, this all sounds great, but how do we pay for it? I think it's really helpful to really have a good understanding of the fact that we do not need to come up with a lot of new money to fix this. I don't care what anybody has tried to put out there. Our healthcare system is awash in money. It's just not going to the right places. We're pretty sure we could fix how we pay for healthcare and cover everybody without spending a lot of new money if we allocate our money more efficiently. So there's more than enough to go around. It just depends on how we decide to organize and pay for healthcare and public health. We already know how to fix this. The legislation is already written. The question is not how to fix. The question is what's stopping us. And really continuing to tinker around the margins with small fixes is in the end not going to work. So very basically, our healthcare industry currently consumes almost a fifth of a $23 trillion economy. Total health spending is $4.3 trillion a year. And health spending in Minnesota was 47.1 billion in 2016, projected to double in 10 years if we do nothing. These are just some kind of basic talking points about our current system. If somebody says, well, we have the best healthcare system in the world, and you can kind of tuck a few of these data points in the back of your mind, and just remember that if we had the best healthcare system in the world, why is it that 1 in 4 people don't get the care they need due to cost? 1 in 5 people can't afford to go to the dentist. Approximately, somewhere between 37 and 45,000 preventable deaths. And there's a whole lot of talking points like this. We will send these slides out to you, and you can take a closer look at it. So I won't go through all of that this evening, but even since the Affordable Care Act passed in 2010, I believe it was, and our insurance exchanges got up and running in about 2013, we still have about 29 million uninsured in this country and about 41 million underinsured because their premiums are so high and their deductibles and copays and out-of-pocket costs are so high, they can't afford to use the insurance that they pay for. We have an actual shocking amount of medical debt and personal bankruptcies related to medical debt in this country. This is what we look like compared to other developed countries. And in Minnesota, I think I said, this is the visual that shows us with a 10-year projection, which is a kind of like a curve that's going straight up if we do nothing. I said that we're not getting what our money's worth. And by that, I mean that our health outcomes are pretty dismal compared to the rest of the developed world. We rank 37th overall in health outcomes and last or near last in system access, efficiency, and equity. So, and this is according to the Commonwealth Fund, which evaluates this every couple of years and prints a pretty extensive report. These are kind of our basic Healthcare for All Minnesota talking points. The ACA, which was supposed to be this dramatic, health system legislation, was really a market-based approach that doesn't control prices and is not going to get us to universal coverage. It was mostly insurance regulation. Two things to keep in mind when people ask you if we can afford this or where are we going to get the money? How are we going to pay for it? Is that under our current multi-payer system, 34 cents out of every healthcare dollar is spent on non-healthcare activities in this country, the administrative costs of our multi-payer system. Medical debt is the leading cause of personal bankruptcy. Out-of-pocket costs are a significant burden for individuals, communities, and small businesses, including farmers. 2/3 of health spending is already taxpayer funded through Medicare, Medicaid, the VA, and other public programs. Plus, taxpayers subsidize employer-sponsored insurance and plans on the exchanges. Our system is massively taxpayer subsidized. And the current system is profit-driven and dysfunctional. And on the policy side of things, we believe that healthcare is a public good, not a commodity. How do we currently pay for healthcare? Well, it's kind of complicated. This whole slide is a list of what makes up our multi-payer system. This is the piecemeal way that we cover people for healthcare in this country. Many of these are public programs put in place to fill the gaps in the employment-based model that uses private insurance. Note, for example, 1,100 federally qualified healthcare centers, which care for millions of people in this country, including undocumented persons. All of this all together is our multi-payer system. And the bottom line is that it's not a system at all. It's a patchwork. This is a Disney, Disney's physician drew what he calls navigating healthcare land. This is his version of how to explain our multi-payer system. Healthcare as a theme park, I guess you'd call it. And then it isn't as though we haven't tried to contain costs. This is the whole alphabet soup of strategies that have been tried over the last 45 or 50 years that you are probably familiar with. You've probably heard these referred to many times as HMOs, PPOs, DRGs, ISPs, ACOs. Rose Roach, our board chair, calls it the EIEIO of our current healthcare financing system. All of this is based on the belief that Americans overuse healthcare and that making it harder to get by throwing up a lot of barriers will reduce costs, and that also that fee-for-service, as in just paying the bills, is the culprit because doctors and hospitals just order too many tests. So these various tactics will cut costs. Well, none of this has worked. So it's all under, this comes all under the umbrella term of so-called managed care. Well, costs have just continued to go up despite all of these bureaucratic programs, all of which actually add a lot of cost to administering our current system. So this mountain of clerical and managerial staff represents the administrative burden associated with our multi-payer system and how it has ballooned over the last 45 years. Administrative costs are a combination of all the billing activities on the payer side and the provider side, as well as the administrative burden of setting up, managing, and reporting data on various and numerous cost containment efforts under our that are currently in place. Estimates are that physicians, for example, spend as much as 2 hours of administrative time for every 1 hour of patient care on electronic medical record and arguing with insurance companies. And just note that little yellow sliver on the bottom that represents a growth in number of physicians over the same time period. We really need more physicians and other providers and fewer of these bean counters, as I used to call them when I was working in the hospital. So here's a picture of a big academic medical center, Duke University Medical Center. The purpose of this slide is to say that Duke University Medical Center employs almost 2 billing clerks per hospital bed. The CEO of Duke said that he has more billers and coders than nurses in his hospital. This is just one example of the administrative burden of our multi-payer system that contributes to the cost of hospitalization. I mean, and if you're wondering why I'm going through all this information, it's really just to sort of drive home the fact that there's plenty of money in the system. It's just going to a lot of useless bureaucratic administrative cost. And then, contrary to what many people think, you can see by this graph, and this is the most recent one that I have, employer-sponsored insurance accounts for just slightly over half of people covered in Minnesota. And then 34% are self-insured, meaning the employer is large enough to cover them. Others offer insurance policies to their employees, individual policies, but larger employers not only see tax benefits to providing insurance, but it also lowers turnover, which saves the cost of training and hiring new employees. Small businesses are at a very significant disadvantage in this system because their cost in recruiting, hiring, and retaining employees is much higher as a percent of their income. The cost of benefits, especially health insurance, is also a deterrent to expanding a small business. It slows entrepreneurial activity. And then please note on this slide that public programs account for about 34% of those covered. And then the small group and individual market are very expensive and require public subsidies to make them even remotely affordable. The uninsured rate is low in Minnesota. It's probably under 4% right now. And this is the most recent number I could find. But it does beg the question of why we need private insurance as an intermediary. And wouldn't it be more efficient and cost effective for the government to pay for healthcare directly? And who depends on Medicaid or medical assistance in Minnesota? 1 in 5 of us, as it turns out. And that is true whether you are urban, suburban, or rural. Almost half of people on Medicaid in Minnesota are children, and about 70% of Medicaid spending is on seniors and nursing homes. So, fun fact, I guess, Medicaid or medical assistance is the largest insurance program, the largest health insurance program in this country, and it's public. And this is just another view of what private insurance contributes to health spending as opposed to other public programs. So just for examples of where our money's going, this is some of the big money going out to United Health Group, which is based here in Minnesota. This is a recent slide of compensation for health insurance executives at some of the bigger companies in the US. A whole lot of money going to overpaid health insurance executives who provide nothing, add nothing to actual patient care. Commercial health insurance is a wasteful, inefficient, unnecessary middleman in our healthcare system that offers no value. And then you often hear that the pharmaceutical industry will claim that they need to charge what they do for drugs because of all that, innovation and research. Well, this slide helps you understand that most of the money they are spending is going to marketing and sales and marketing, not to research and development. The public pays for the vast majority of research and development for new drugs in this country. And actually, I'd like to know where my return on my investment is. I couldn't find a slide of the compensation for CEOs of pharmaceutical industries, but trust me, it's even worse than the insurance industry. Ditto for devices and diagnostics. But this is just to help you be grounded. Also, they spend a lot of money on stock buybacks to increase the value of their stocks for shareholders and shareholder return. So very little, contribution to actual development of new drugs. They spend more effort on drugs that are commercially valuable to them than actually meet the health needs of our public. So what's the fix? That's what you're going to be talking to people about for the most part. I've just got a slide that reviews the legislation for a state-based single payer system for Minnesota, and also for a national single payer improved and expanded Medicare for all. We have a lot of information about why we need the big fix, some possible interim steps, and why we believe that we're past the point of slapping another Band-Aid on this broken healthcare payment system. There are a number of programs available for you on our YouTube channel and other sites. But for this training, I'll just go over the most recent legislation and current proposed legislation. So the Minnesota Health Plan for a state-based plan, where I guess you could think of this as a dual track toward a national health program, which we all agree is the best ultimate solution. The Minnesota Health Plan was reintroduced in 2023. These are the bill numbers. No hearings have been held on these bills yet. A state-based plan would require enabling legislation by Congress to fund this program. We did get in 2023, in the 2023 session, a cost analysis bill passed and funds were appropriated for a single payer system for Minnesota. And then the Medicare for All Act of 2023 was reintroduced, the House and Senate versions, on May 17th, 2023 in Washington, D.C. A national health plan would be best for funding reasons and for efficiency. If anybody asks any specific questions, the Indian Health Service and the VA, Veterans Administration, would remain as they currently are. We do know that a number of, quite a few Native Americans also utilize medical assistance in addition to the Indian Health Service. And there's the difference between a state-based plan, or one of the main differences between a state-based plan and a federal or a national health plan, are that if we passed a Minnesota health plan or a state-based health plan, we would probably need premiums based on ability to pay. We also would need enabling legislation by Congress for funding to get access to some of the federal funds that currently go into the system. A federal plan or a national health plan both would be universal coverage, but a federal plan is proposed to be taxpayer funded. Both plans are proposed to be avoid or eliminate out-of-pocket costs, to eliminate out-of-pocket costs as a barrier at the point of care.
And I just want to point out that it is now 7:46, so we probably need to wrap this up to allow people.
Okay, just key provisions of the state plan, and I'll let you look at this on your own. Senator Marty wrote the book, and this is available online on the mnhealthplan.org and also on our website. If you're interested, it's very good. I really encourage taking a look at this book. The Medicare for All, the National Health Plan, very similar provisions. Both are very comprehensive, and we have other training that goes into a little more detail about the provisions and principles behind both of these. We hope to get past the point where we're slapping a Band-Aid on our current system. We all believe that, those of us doing a lot of this work, as an incremental change is tempting, but not the answer. We do understand that we will have to have probably some interim steps toward an eventual state-based health plan and a national health plan, but we hope that those are based on good principles and good legislation going forward. Sounds great. How do we just a quick word about women's reproductive health, since it's such a big issue. Both the state plan and a national health plan would provide payment for full reproductive services for women and all genders. Coverage for this does not make them legally available. However, we also need passage of the Women's Health Protection Act of 2021. That's a bill in Congress. And then universal coverage means everybody in. The Minnesota Health Plan would cover all permanent residents of Minnesota. If you're, these are just a couple of details, regardless of citizenship status. And if people ask you, does all mean all? The answer is yes, all means all. And Medicare for All would cover all permanent residents of the U.S. regardless of citizenship status. And I suggest that we just state the facts and not try to defend or explain. Sounds great, but how do we pay for it? I think I've already referred to the fact that, how much waste we have in the system, but just kind of something to keep in mind is that estimates are that we could save about half of the administrative cost currently being spent, that 34 cents out of every dollar spent on total health spending right now, which is about $600 billion a year. And that is enough to cover everybody and improve benefits. And that the proposal at the national level is that we just increase the FICA tax to pay for it, which people are already familiar with. Now, this is not me saying this is how it will actually come out, but this is one very serious proposal and very feasible proposal that most people would be familiar with. We already have, payroll tax. This would just bump it up enough to cover a national health plan. So the simple answer is that there is already enough money to go around if we are willing to reimagine and how we organize and pay for healthcare in this country. Some of the things we're up against, I will just kind of go through these quickly. We're there to create grassroots support for change. So we need to turn public opinion into political will. And that's why we're out educating and organizing the public to push for change. We're trying to bring more people to the fight and create more activists. These are some of the many ways we are working to get out in the public and build create more of us, I guess, and build political will for change. And in the end, it's about social justice, everybody in and nobody out. As Martin Luther King said in his letter from Birmingham jail back in 1963, injustice anywhere is a threat to justice everywhere. We are all in this together. These are just a couple more resources. The rest of the slides are a lot of resources that you can go to. I'll mention a couple things. This news column by Wendell Potter has a ton of information about where our money's going, and the Health Justice Monitor on the bottom is a good information on health policy related. All of these other websites are organizations who are with us in this fight, including the Labor Campaign for Single Payer, Public Citizen, Healthcare Now, all well worth you checking out. And I'll just ask for if anybody has questions right now.
And I just want to talk for just a minute, because I'm sure some people on this call know about the public option bill that has been
sure,
and so they may get some questions about that.
Yes.
Excuse me. Healthcare for All Minnesota, I will speak for, and then Dr. Crossan or Jen can speak regarding PNHP if they have an official stance on it. We have not taken official stance on the bill because there are key questions that we need to get answered that we have not gotten answered. One of the most specific ones is, how much is this going to cost people? Like, how much are these premiums going to be? Is it going to be affordable for people? Also, who all will it include? Is it only going to be 3% or is it going to be more people? So we are trying to work somewhat behind the scenes in influencing what that public option bill would include in order to make it a stepping stone towards something like the Minnesota Health Plan, because it would not be an end goal. So it would be kind of sort of a step, but again, sometimes you have to negotiate, sometimes you have to compromise in order to achieve goals, and this may be one of those times and situations. So once we know those informations, we will take a stance on it. But as of now, we have not taken a stance on it. And the main reason being is what is written in the bill is not clear. It is not clear as to what it will include and how much it will cost.
Well, the other issue, Judy, that we have to determine is if the public option would have private insurance tied to it or not.
Correct.
We are not going to accept any public option that is privatized.
Thank you. I did miss that part, and that is very important. So thank you for pointing that out to me.
Right.
Or to everyone, I should say.
If people happen to know that a prescription drug pricing bill or board did get introduced and passed, but it seems to have fairly limited scope at this time.
Right.
So again, we're monitoring that to see if it's useful.
There is some questions here, and I'm just looking through the chat. Jean Foreman asked, is it state-based insurance? But I don't know what that was in regards to when she posted this question, and she is not on the chat anymore. She had to step away. I will follow up with her on that one. She also asked if she can bring and store a backpack. Yes, there will be some space, not a ton of space under the tables that you can store a backpack or a purse. You are allowed to bring a backpack or a purse into the fair. They will check it. They will look through it to make sure. You do have to go through a metal detector. So just know that last year, every time I walked through, my purse rang. I don't know. There's something in my particular purse that made the metal detector ring. It's just a fact of life, unfortunately, here in the U.S. We will be sending the slides out. Are there going to be chairs if you want to take a short sitting break? So I will be bringing some stools, some bar height stools that do have a back and some cushion that people can sit on. And then we will also have a chair, like a camping chair or two underneath the table if anyone cannot sit on the bar stools. So those will be available. Know that there is that camping chair under there if you need to sit down and you can't. And I think that might be the last question. If anyone has a question that has not been asked right now, feel free to unmute yourself and ask it. If you have questions later too, you can always email us at info@hca-mn.org and we will answer your question. Does anyone have any questions they want to ask? Dr. Crossan?
Yeah, while everybody is on this call, is there anything more that we can do at this point in time to get more volunteers?
Just ask people. And if they are interested, send me or Ann their phone number, or Jen their phone number, and we'll call them and try and get them signed up. If, you know, again, we're recording this, there are some people who have emailed us and said they couldn't attend this training tonight and how can they view it. So that's why we're recording it. So we'll send that out to everyone who volunteers. So if we have a new volunteer sign up after I send out the recording and all the resources, I'll just forward that on to them.
Good.
It looks like if people ask you what we need, let me see. Shoot. Here. We are, Labor Day weekend is a little bit short yet, but we have a little bit of time to help fill that in. August 26th, Saturday is a little short still, if people are interested in knowing what's open.
Mark, did you have a question?
You're on mute, Mark.
Mark, you're on mute.
Mark, on mute.
Thank you. Just a comment. We do have something that we haven't had in the past. We have some pens with the Healthcare for All Minnesota logo on them. And people frequently like to get things from Booz. Freebies are typically popular. But we have a limited number of pens. We have approximately $50 per day for the fair. So I would suggest that rather than just having them out on the table and having them all gone in the first few hours by everybody who walks by, that we reserve them for the people who we've had some conversations with and people who've
Okay.
used their phone to get on the contact list or used the computer to get on the contact list. So anyway, you can't tell from from the computer screen, but they're blue. They have a white logo on them, and I think it's a way of giving people something where they will be reminded when they use it about healthcare and the need for healthcare finance.
There it is.
There's,
Thanks,
there's
Judy.
Judy.
So
If
that's an excellent point, Mark. We only have a very limited number of these. And so we want to try and give them to people who are taking a step to get involved, either having a good conversation with you, sign up for it, not to the kids necessarily running by collecting stuff, because they're not cheap to buy these kind of things and whatnot, but know that they're there as a resource for you when you have that conversation with somebody.
Now, if you only signed up for one shift and you want more, we do have some openings. I spent quite a bit of time at the fair last year. It was fun. It was good. So, we have Saturday. I see you down, Wally, twice. Thank you so much. Yay. Yay, you. We have openings on Saturday and then later on in the week, Wednesday, and then I guess Friday and Labor Day weekend. We'll have to do some more recruiting. Talk to your friends.
Last year we had some people volunteer midweek during the fair for this was the same issue we had last year, as Labor Day weekend is a little tough. But that's okay. I just want to thank everyone for attending tonight. And again, if you have any questions, don't hesitate to reach out to us and we will get back to you. Thank you.
Thank you.
Thanks all.